Hello, students. Let us quickly see what the ENT questions of INI-CET May 2024 were. So, having a quick look at the distribution of the questions, we had three questions from ear, one from nose, two from pharynx, and one from larynx. So, let us start. The first question, all the following are features of otitis media with effusion except. So, what is being asked is which of the following is not a feature of otitis media with effusion, that is serous otitis media. So, the first choice, most cases have a D type of curve on tympanometry and a conductive hearing loss. Serous media, yes, the hearing loss is conductive, but the curve on tympanometry is not AD type of curve. AD is seen in ossicular discontinuity, whereas in serous media, what is the curve that we see? So in serous media, the eustachian tube is blocked, because of which there is negative middle ear pressure. And because of fluid in the middle ear, the compliance, that is the tympanic membrane mobility, goes down. That leads to the B type of curve, that is also known as the dome type of curve. And if the fluid is so much that there is no mobility at all, that can also lead to a flat curve on tympanogram, right? So this is the incorrect choice. The second choice usually occurs after an episode of common cold, but can also occur without it. So yes, it can follow viral infection, that is common cold, where the virus can lead to damage of the mucociliary epithelium, leading to eustachian tube dysfunction. But if I ask you that most common cause of serous otitis media, the usual cause in children is, yes, that is the obstruction of the eustachian tube drainage by a mass in the nasopharynx. And this mass in the nasopharynx of a child is most commonly adenoid hypertrophy. And is adenoid a midline structure or lateral structure? It is a midline structure, so it obstructs both the eustachian tube. So if the serous otitis media is because of hypertrophic adenoid, then this is usually bilateral. And let me ask you another very important question. In adults with unilateral serous otitis media, it is mandatory to investigate for which condition? Yes, for nasopharyngeal mass, that can be nasopharyngeal carcinoma. So in adults, the nasopharyngeal mass can be nasopharyngeal carcinoma. Adenoids are not present in adults. So in adults, if there is unilateral serositis media, that can be because of nasopharyngeal carcinoma. And since nasopharyngeal carcinoma arises from just behind the eustachian tube, it obstructs only that particular eustachian tube, leading to unilateral serositis media, right? So in unilateral serositis media in adults, always rule out nasopharyngeal carcinoma. And also another important cause of serositis media is eustachian tube dysfunction because of abnormal functioning eustachian tube muscles which open the eustachian tube, like the tensor palate, elevator palate, which happens in cleft palate. So these can be the various causes. So yet it can occur following common cold, which is true. It resolves on its own after the symptoms subside. So if it has followed a viral infection, or if it has followed allergic hypertrophy of the adenoid, then once this condition subsides, the serositis media will also subside. All we can ask the patient to do is autoinflation, that is by Valsalva or by polysterization. If it does not benefit by this, and if the cause is a hypertrophic adenoid, as occurs in allergic condition, then in that case, we aim by medical management to reduce the size of the adenoid by giving the patient nasal steroid sprays, right? So the first management of serositis media, always remember, again, this has been a question of your exam. The first management of serositis media is always medical. Again, was a question of your exam that medical management is given for how long is serositis media? For at least 3 months. If the patient does not benefit, only then we think of going for surgical management, right? So it resolves on its own after symptoms subside. That is true. It is usually bilateral. Yes, it is usually bilateral. So again, serositis media is a very, very favorite question of your exam. Whenever there is a child, the presentation that is given that it is a child with bilateral hearing loss with nasal obstruction, always think of serositis media. Now, this has been consecutively third year where this question of serositis media was asked. In 2022, what was asked was the presentation was given child with bilateral hearing loss, and this picture was given with the fluid, the air bubbles behind the tympanic membrane, and what was asked was the diagnosis. Now, last year, what was asked was again the presentation was same, but instead of this picture, what was given was the tympanogram finding of B type of curve. And what was asked was the management. How will you manage this child? So in the choices, what we had was all the surgical management was given. The myringotomy with grommet, myringotomy with grommet with adenoidectomy. So what will be the best answer here? Yes, the best answer will be myringotomy with grommet with adenoidectomy. And again, previously has been asked that medical management is given for how long is serositis media? It is given for at least 3 months. Again, in your exam has been asked what is the shape and the site for incision for myringotomy in serositis media. So it is an anteroinferior radial incision. And this was a picture that was given in NEET and was asked the spot diagnosis. So this is myringotome through which we do myringotomy, right? So coming to the next question, which of the following is not recommended in an 8-year-old child with bilateral sensorineural hearing loss? So here we have an 8-year-old child with bilateral sensorineural hearing loss. What are we not going to do for this child? So the first choice, adenoidectomy and grommet insertion. So do we do it here? We just saw that adenoidectomy and grommet is done for serous otitis media, and serous otitis media will lead to what hearing loss? Conductive hearing loss. Serous otitis media, so no, in bilateral sensorineural hearing loss, it will not be done. Hearing aid, what do hearing aids do? Hearing aid collect the sound and they amplify it and send it forward to the ear. So hearing aid can be used in any hearing loss, be it conductive or sensory or neural, or we can call it be it conductive or sensorineural hearing loss. So this can be used for both conductive hearing loss as well as sensorineural hearing loss. Can you tell me any condition of conductive hearing loss where you give hearing aid? Yes, that is again a question of your exam. Yes, which condition is that? Yes, a condition of the middle ear where we are not able to operate or surgery is contraindicated. In some cases, yes, otosclerosis. In otosclerosis, when the patient is not willing for stepidotomy, then we go for hearing aid. Now, one limitation of the hearing aid is that hearing aids do not function well if the hearing loss is too much, if it is more than 80 decibel. So, in patients who have bilateral, severe to profound sensorineural hearing loss, so in these cases, we go for cochlear implant. So, cochlear implant is bilateral, severe to profound. Yes, so how much is profound hearing loss? Profound hearing loss is more than 90 decibel. Yes, severe to profound sensorineural hearing loss. We go for cochlear implant, and whenever we go for cochlear implant, it is mandatory to give a hearing aid trial because hearing aids are not invasive. So if the patient benefits by hearing aid trial, then that is not an indication of cochlear implant. Now, so can we go for cochlear implant also here? Yes, we can go for cochlear implant. We can go for hearing aid. Now, some students told me that it is an 8-year-old child. Will we still go for cochlear implantation in this child? What do you think? See, cochlear implantation, the main indication is that the hearing loss should be bilateral, severe to profound hearing loss. And this hearing loss can be either prelingual, right? Or it can be postlingual. Postlingual. Now, what's the meaning of prelingual hearing loss? Prelingual hearing loss means that the child has become deaf before the development of language, which means that the child is congenitally deaf. The child has never learned how to speak. So in these cases with prelingual hearing loss, the cochlear implantation has to be done as early as possible. Yes, it is done as early as 1 year of age so that the neuroplasticity develops, the understanding, the language development is proper. Whereas in postlingual deafness means that the patient already knows how to speak the language, the speech, everything is well developed. Now the patient has become deaf. For example, if it is a 7 or 8-year-old child who already knows how to speak, but now because of either trauma or because of meningitis leading to labyrinthitis, the child has become deaf. Or it is an adult with meningitis who developed hearing loss, or adult with sudden sensorineural hearing loss, or even if it is an elderly with presbycusis with bilateral severe to profound hearing loss. In those cases which are postlingual, cochlear implantation can be done at any age. Their age is not a limitation. What is important there to remember is that the cochlear implantation should be done as early as possible following the onset of deafness, which means that the duration between the onset of deafness and the cochlear implantation should not be too much. The auditory deprivation should not be too much. Is that clear? So in this child, it is not mentioned it was a prelingual or postlingual. Can we go for cochlear implantation? Yes, we can go for. Sitting in the front row of the class, so can that benefit in hearing loss? Yes, that can benefit, because in the front row, definitely the loudness of the teacher, of the speaker will be more. Also, these kids who have hearing loss, they use a lot of visual cues to understand. For example, the facial expressions, the gestures, the lip movement, they do a lot of lip reading. So yes, these patients are always made to sit on the front row of the class. So that is also true. So not recommended is adenoidectomy with grommet. And that was a very straightforward question. Even the rest of the things, if you did not know, you definitely know that adenoidectomy with grommet is done in serous otitis media, which leads to conductive hearing loss, not sensorineural hearing loss, right? So the next question, a patient presents with sudden onset, lower motor neuron facial paralysis on his left side. Radiological test showed no deficits. What is the next best step in the management? So here we have a patient of left-sided facial nerve palsy. And what is mentioned here, it is acute onset palsy, and radiological test show no deficit, which means that this is not a facial palsy which is followed otitis media. Middle ear is normal. This is not followed trauma. The radiological test is not showing any fracture, right? So what is the diagnosis? What is acute onset lower motor neuron facial nerve palsy, which is idiopathic? Yes, that is Bell's palsy. So in other words, what is being asked is, what is the next best step of this of management in a patient who is presented to you with Bell's palsy? So this IV antibiotics and mastectomy, no. This Bell's palsy is idiopathic. Though in 60% of the cases, a viral prodrome has been found. And again, that has been a repeated question of your exam. Which virus? Which is HSV1. So no role of antibiotics and mastectomy. This cannot be. So steroids, acyclovir, eye patching, and eye ointment. Yes, this exactly is the management. In fact, even if steroid was given in the choice, we would have marked that as the answer as the next best step for management for Bell's palsy. And again has been asked that acyclovir has to be given if the patient has presented within how much of time? Yes, within 3 days. Within 3 days, in less than 3 days. Electrical stimulation of the facial nerve, is that done for Bell's palsy? Yes, it is done. But if we are supposed to choose the next best step, that will not be the electrical stimulation, that will be steroids. So no, not this. And facial nerve decompression, can that be done for Bell's palsy? Yes, that can be done. In which cases? When the Bell's palsy patient is on steroids and not recovering at all, and also the electrophysiological test, the electroneuronography, the tests are showing that there is progressive degeneration, there is poor recovery, there is no recovery at all. The patient is not benefiting. In these cases, we go for facial nerve decompression. And again, has been a question asked here that if in Bell's palsy, we have to go for facial nerve decompression, which segment of the fallopian canal will be decompressed? Tell me. So yes, as I told you that 60% of the cases are have a viral prodrome. So in these cases, because of viral infection, there is inflammation, there is inflammatory edema, and the fallopian canal being narrowest in the labyrinthine segment, it is in the labyrinthine segment that the compression leads to ischemia and patient of palsy. So if we have to decompress, we will have to decompress which segment? The labyrinthine segment. But yes, this will not be the next best step. So the next best step will be steroids. Now again, facial of palsy was a question that was asked last year also in your exam, that was a NEET. And what was given was just this much, that this is a patient, the picture was given with the complaint of inability to close the eye and deviation of angle of mouth, which shows that there is complete involvement of one half of the face, which means it is a low motor neuron palsy. And was asked was which nerve is involved in this patient, right? So which nerve? This is facial nerve. So coming to the next question, which of the following is typically not seen in allergic rhinitis? Allergic salute, is that seen? What is allergic salute? Yes, patients of allergic rhinitis have a lot of itching, sneezing, runny nose. So they have this gesture of rubbing the nose either in the upward or in the transverse direction. And this gesture is what is known as allergic salute. So yes, we do have a picture of this. This is what is allergic salute. And because of this repeated gesture, what happens in these patients is that a transverse crease forms just above the tip of the nose. This is what is known as allergic crease. Allergic crease. So this is again a feature, a spot diagnosis of allergic rhinitis. These patients also have dark discoloration below the eye and puffiness below the eye, and this is what is known as allergic shiners. And because of the puffiness below the eye, which is because of venous congestion, because of nasal obstruction, they also develop folds in the lower eyelid, and that is what is known as Denny Morgan lines. Again, a very important feature of allergic rhinitis that has been a repeated question of your exam is on anterior rhinoscopy. How do you differentiate it as allergic rhinitis or vasomotor rhinitis? In allergic rhinitis, always the mucosa inside the nose on anterior rhinoscopy is a pale, boggy mucosa, right? So these are the features of allergic rhinitis. So let us see. Yes. Allergic salute. Yes. Allergic shiners. Yes. Denny Morgan lines. Yes. Otto-Verguth folds. What are these folds? Otto-Verguth fold is a fold of the skin of the upper eyelid, and this is a feature of chronic depression. So this is a very straightforward question. The next question, 13-year-old male patient presents with unilateral nasal obstruction with recurrent episodes of epistaxis for past 6 months. What is the most likely diagnosis? So again, this is a very straightforward question. An adult pubertal male with unilateral nasal obstruction, recurrent epistaxis. What do we have to rule out? A repeated question. Yes, this is juvenile nasopharyngeal angiofibroma. And let us see the choices. Antroconal polyp. Antroconal polyp can occur at this age, but it will not lead to epistaxis. It can lead to unilateral nasal obstruction. So note, this cannot be the answer. Juvenile nasopharyngeal angiofibroma, yes, we know that is the answer. Coagulation disorder can lead to epistaxis, but will that lead to unilateral nasal obstruction? No. And allergic rhinitis, that can lead to nasal obstruction, but not never epistaxis. So yes, the answer is juvenile nasopharyngeal angiofibroma. And again, this has been consecutively the third time where this question of angiofibroma was asked in your exam. Yes, previously what was asked was, again, this presentation was given a young male with unilateral nasal obstruction with recurrent episodes of epistaxis. And this picture was given. The endoscopy shows a red fleshy mass and the CECT shows a enhancing mass. What was asked was, what is the site of origin of this tumor? So it is understood that you have made the diagnosis of angiofibroma. So yes, the site of origin is sphenopalatine foramen. Again, previous to that year, what was asked was, again, the same presentation was given. What was given was that there is a red fleshy mass in the nose going up to the sphenoid sinuses. What is this stage on Brodowski's classification? So yes, this is the 1B. So that is very, very important for you to know. It has been asked twice, the Brodowski's classification. And I have always told you that remember it like this. The medial spread from the sphenopalatine foramen, that is into the nose, is 1, right? So if it is just into the nose, it is 1A. If from the nose, obviously, it will go into the sinuses. So if from the nose, it is going into the sinuses, that is 1B. Medial spread is 1. 2 is lateral spread. So 2 is lateral spread means lateral means where does it go? Into the sphenopalatine fossa. So if it is little spread into the sphenopalatine fossa, that is 2A. When it is extensive spread into the sphenopalatine fossa, completely filling it, going into the orbit also, that is 2B. And when it goes further laterally into the infratemporal fossa, that is 2C. Intracranial spread is 3, minimal involvement is 3A, and extensive unresectable disease is 3B. Now, again, important for you to remember is that except for 3B, where the tumor is intracranial and unresectable, the main management of angiofibroma is surgical excision. Only in these cases of 3B, where the tumor is intracranial and unresectable, we go for radiotherapy. So again, here is very important for you to know that if at all we are operating the patient, which is the main management for angiofibroma, we need to go for pre-op embolization. So which is the main arterial supply of nasopharyngeal angiofibroma? Again, has been a question of your exam. So that is the maxillary artery. The maxillary artery. So the next question we have here is, what are the structures passing between the areas marked A and B? So what are the structures marked A and B here? A is the superior constrictor, B is the middle constrictor. So it is this gap that is being asked. So what are the structures that pass through here? Yes, we have the ninth cranial nerve, that's the glossopharyngeal, along with the only motor supply of the glossopharyngeal, that is the stylopharyngeus. Yes. Okay, so we have the other gaps also, which are important for our exams. So we need to know that. So we have the gap in between the base of skull and the upper border of superior constrictor. What is that known as? That is known as the sinus of Morgagni. And what are the structures that pass through here? Yes, how do we remember it? The mnemonic is Thala, T-A-A-L-A. So it is Thala and it is all palati, palati, palati. Just remember like that, right? So it is tensor palati, ascending palatine artery, palatine branch of ascending pharyngeal artery, levator palatine. And the last A is the auditory tube, that is the eustachian tube. And this area is involved. The sinus of Morgagni is involved in patients of nasopharyngeal carcinoma, where these structures get involved, leading to the sinus of Morgagni syndrome. Yes. So the next gap is in between the superior and the middle constrictor. Yes, through which enters the upper nerve of the pharynx. So in the pharynx, we have two nerves. We have the ninth and the 10th. The upper nerve is the ninth. So that passes through the next gap, that is in between the superior and the middle constrictor. Through the next gaps will pass the branches of the vagus, the 10th nerve, right? So how many branches of the vagus to the pharynx? Two branches. The upper branch is the superior laryngeal, lower is the recurrent laryngeal. The superior laryngeal again divides into two. It is the internal laryngeal and the external laryngeal. And the name itself tells external laryngeal does not enter inside the pharynx. So we have two branches of vagus entering into the pharynx, the internal laryngeal and the recurrent laryngeal. So then through the next gap, that is in between the middle constrictor and the inferior constrictor, will pass the internal laryngeal nerve along with the superior laryngeal vessels, and through the in between the inferior constrictor and the esophagus, that is through the lower border of the inferior constrictor, passes the recurrent laryngeal nerve along with the inferior laryngeal vessels. So let us see the choices. Recurrent laryngeal nerve and inferior thyroid vessels, they will pass in between is the inferior constrictor and the esophagus. So no, not this. Internal laryngeal nerve and superior laryngeal vessels, that is the upper border of inferior constrictor, that is in between the middle and inferior constrictor. So no, not this also. Auditory tube and levator palatine, this is passing through the sinus of Morgagni, that's the base of skull, in between the base of skull and the upper border superior constrictor. So no. So answer is glossopharyngeal nerve and stylopharyngeus. Yes, this is the answer. So the next question, a patient with papillary carcinoma thyroid underwent a thyroidectomy. Post-surgery, she complains of hoarseness of voice. Which of the following steps in surgery could not have caused this symptom? Right? Okay, so here, these type of questions are absolute favorite of INI-CET exams. Repeatedly for the past 4 to 5 years, they have been asking these type of questions. Sometimes they say that there is a surgery that has been done in the lateral base of skull or the carotid triangle or the thyroid, following which the patient has developed some change of voice. Yes, so which is the nerve that is injured is what you are expected to tell always. So yes, I have always told you that always see which is the surgery, in which area the surgeon is operating. Accordingly, you will narrow down the choices. So if this is a patient where thyroidectomy was done, which branches of vagus can be injured leading to alteration of change of voice or leading to any symptom post-surgery? Yes, so if it is a thyroid surgery, post-thyroid, what can be injured during thyroid surgery is only two nerves, either the external laryngeal nerve or the recurrent laryngeal nerve, right? So which out of these are most commonly injured? If I ask you, yes, the external laryngeal is injured most commonly. Now, if the external laryngeal gets injured, there is, yes, injury to which muscle gets affected? The cricothyroid, and cricothyroid is the main tensor. So if this is affected, what will happen in patient is there will be inability to raise the pitch of voice. right? Whereas if the recurrent laryngeal nerve is injured, then recurrent laryngeal nerve injury can be either unilateral or it can be bilateral. If there's unilateral injury, that will lead to hoarseness. Whereas if there's bilateral injury, that will lead to stridor, that will be life threatening. In fact, this is the injury that has been asked repeatedly in your exam. Yes, following total thyroidectomy, extubation was not possible. Patient was in stridor. So, which nerve is injured? There's bilateral recurrent nerve injury. So now, just by reading the question, we know that in this patient following thyroidectomy, there is unilateral recurrent laryngeal nerve injury. So what is being asked is, which steps could not have caused this symptom? Okay. So the first choice, ligation of vessels near the superior pole of thyroid. Can this cause injury to the recurrent laryngeal nerve? At the superior pole of thyroid, we have the superior thyroid artery, along with which goes the external laryngeal nerve, right? So, superior pole of thyroid will not injure the recurrent laryngeal nerve. The recurrent laryngeal nerve is associated with the inferior pole of thyroid, where we have the inferior thyroid vessels, right? So, the next choice is division of Berry's ligament, dissecting around Behr's triangle, dissection close to tubercle of Zuckerman. So what are these? Yes, so Berry's ligament is, we know, a condensation of the pretracheal fascia, which adheres the thyroid gland to the trachea. And during division of removal of the thyroid, this is one of the last steps that we do, is dissection of the Berry's ligament. And this Berry's ligament is in very close relation to the recurrent laryngeal nerve. In fact, this is one step which very, very commonly injures the recurrent laryngeal nerve. Now, in some people, also there is a posterolateral extension of the thyroid, which is the tubercle of Zuckerman, and that is also, as we can see here, in close relation to the recurrent laryngeal nerve. So, yes, it can be injured while dissecting in this area. And what is the Behr's triangle? Yes, that is again very commonly asked in your exam. So, Behr's triangle is a triangle. When the patient lies down, the base here is formed by the common carotid. The superior limit is the inferior thyroid artery, and the lower limit is the recurrent laryngeal nerve. So, yes, while dissecting the Behr's triangle, also there can be injury to the recurrent laryngeal nerve. So, what is the answer here? Yes, it will not be injured definitely while operating on the upper pole of the thyroid. So, the answer here is A, right? So that brings us to the end of these questions. And we can see that this time, most of the questions were very predictable. They were all asked from the important topics. And yes, there was a slight change in the way they were asking the questions, but the topics and what they wanted to ask more or less remained the same. So I hope you were able to answer all of them.